And Clara, can someone go over and tell the folks over there to start coming back? All right, well, I'm going to get going. I'm extremely appreciative that Dr. Prados would come up from UCSF to give an overview of work going on there, and especially his passion and focus, which is pediatric brain tumors, which don't get as much attention as I believe they should. I was a resident at UCSF in the last millennium, and I cut my teeth in brain tumor neuro-oncology with the neuro-oncology clinic under the guidance of Dr. Prados and a new fellow who had just shown up named Dr. Suzanne Chang, who Dr. Wilson called Susan, and Mary Lovely, who is here somewhere, was on the staff and was our patient nurse advocate, and Mary's here in the back. So we have some of the old guard from UCSF days here. And Dr. Prados has been a passionate advocate for brain tumor patient care and research, and involved in the SPORE grants at UCSF since the early 90s when I was there, and even before. And so I appreciate him coming to give us an overview of new strategies for the management of a pediatric tumor he's passionate about. Thank you so much, Mike.
Yeah. Thank you. So I am, last year I talked about adult glioblastoma, and I wanted to kind of bring it to something a little bit different that I'm particularly focused on right now, which is pediatric glioma and brainstem glioma in particular. And I've titled this Therapeutic Strategies for an Incurable Cancer, and that's exactly what it is, unfortunately. One of the first patients I ever saw at UCSF in 1985 when I came there was a child with brainstem glioma from Indonesia, and I have to say that even now, after all these years, the outcome's really not changed. It's a very difficult problem. So I'm going to go very quickly through this. It's more clinical than translational, but and I'm going to talk about the kind of the strategy we have through what's called the Pacific Pediatric Neuro-Oncology Consortium, which we started about 4 years ago with a couple of like-minded pediatric neuro-oncologists who felt like we had to do something different to try and make a change. So high risk, high reward, do something we hope is significant, and take chances to try and make a difference in the disease. And we decided to do this outside of the context of the NCI because we felt we would have more freedom to do that. And that has challenges of its own. So this was our strategy about 3 years ago in terms of how to tackle the disease, and I'll tell you why we got to that in a minute. But basically, we wanted to have a precision approach. We wanted to have a convection-enhanced delivery approach because of the issues about drug delivery, and we wanted to have various immunologic approaches. And we set out to try and do that, not only to create the trials, but also to get the funding for it. So for those of you who don't deal with kids with brain tumors, they have a wide spectrum of different kinds of diseases, and a lot of them are very well managed. A lot of them are what we call lower grade tumors, and the idea here is to take care of them without hurting them, but there are about a half of them that are gliomas, and a small portion of those gliomas are high grade. And the brainstem tumors represent about 12 or 13% of those gliomas. But if you look at the cause of death, that small group of children represent a disproportionate number of children who die of brain tumors. So that's the disease, and location. Now I have a slide about that, but the disease originates in the pons. You can't live without the pons. And it's very clustered among children who are between the ages of 5 and 10. I mean, you rarely see it outside of that age group. And it's a difficult process when a child comes in with their parents They have a very short clinical history, scans done, DIPG, diffuse intrinsic pontine glioma. The parents get on the web and they know immediately that their child is going to die. And that's essentially the decision-making process when you talk about different options. What can I do so that my child will live? Median survival has not changed in 50 years. And the median survival is about 9 months. When a patient progresses, which is usually in 6 or 7 months, they usually only live about 2 or 3 months after that. So that's worse than glioblastoma. The disease, fortunately, is not common, only about 300 or 400 kids per year. So it's a very rare disease, but it's obviously very important, right, for every child that comes. In the past, what we've done, which is very empiric, we would take drugs that were used for adults and then put them in kids and assume that those gliomas in adults would translate into therapeutic success in children. And that's always been wrong. This was a quote that Nalan Gupta, one of our pediatric surgeons, found in a chapter in a book back in 1996. That was the story back then. And because we thought we were so smart with MR imaging, the decisions through the Children Oncology Group and other groups was use the MRI scan, don't get tissue. So for the last 40 or 50 years, people have not been getting tissue. So we don't know, we never knew the biology of the disease that we were treating. We were just treating an image, an MRI scan, and never figured out what the underlying biology was. Back in 2006, as part of the Pediatric Brain Tumor Consortium, we felt that we had to change that paradigm and to get tissue from all of these kids because we didn't know what we were treating, the underlying biology or the disease. And at that time, CTEP, the NCI, said no, it was too risky to do that. When in fact, children had been getting biopsies of their pons for many years before that, and in Europe, they were way ahead of the curve getting tissue, and they were starting to understand the underlying biology. But we couldn't get it through. Finally, we opened up a philanthropically supported study that came out of Dana-Farber. But the point here was it took 6 to 10 years to try and even start the process of getting tissue to help us understand what the disease was we were doing. And the trial that was attached to that early study was just basically using information from adult glioblastoma and hoping that it would make a difference. This trial was just completed last year. We have 25 institutions that were involved. What came out of it more than anything else was the genomic profiling that we were starting to understand. And it turns out that there is a significant difference from glioblastoma. Even though these children ultimately die of what's called glioblastoma, it's very different than glioblastoma in adults. The genomic underpinnings are completely different than what you would see in adult glioblastoma. And all of the therapies that we were using in the past that were focused on adult glioblastoma, of course wouldn't work. Of course wouldn't work. The other issue about pontine gliomas is that in some brain tumors, in effect, these are kind of bland in terms of genomic alterations. So we say that there's heterogeneity, there is, but the kinds of mutational loads or the alterations that occur in these children are actually quite small. And it's interesting that these children die so quickly with a disease that isn't so genomically complicated. But that's truly the case. About 4 or 5 years ago, a critical piece of information was finally uncovered based on the fact that children were now getting tissue and the underpinnings that genomic profiling, good platforms for looking at alterations were coming into play, and an epigenetic mark was discovered called the H3.3 K27M mutation, which is really only seen, ultimately in children who have brain tumors and brain tumors that are in the midline. So this is an epigenetic regulator that was discovered just very recently, and an awful lot of emphasis is now being placed on what to do with it. This mutation that's found in DIPG changes the amount of methylation, if you want to think, the trimethylation that occurs near the epigenetic regulators, the PRC complex, and it changes globally a gene expression both up and down along the genome in a very very complicated fashion. But this is actually an important target. It's one of the few mutations that occur in DIPG. It occurs in about 70 or 80% of children with DIPG. When it occurs, those children have the worst prognosis. They do worse than children who don't have that mutation that still have DIPG. So it's an important finding. It's one of the very few critical findings that have actually driven the way that we think about the disease. And you can see in this kind of spectrum here that it's restricted to children, it's restricted to diseases in the midline, and it has the worst prognosis of all the gliomas that you can see here, adult as well as children. And topographically, this is where these diseases occur in the midline. So we actually now are starting to think about not only DIPG as being restricted to the pons, but a spectrum of diseases in the midline thalamus, pons, that all have the same unique biologic characteristic and driver mutation called the H3.3 K27M mutation. So knowing that, what do you do? Well, the ideal pipeline would be that now that you understand a little bit about the biology, you can start to create model systems and then do clinical trials. But we wanted to do this as quickly as we could to make things happen. This was a child that we saw at UCSF about 7 or 8 years ago with DIPG. This little girl underwent a series of biopsies. We developed a good xenograph. The xenograph had the K27M mutation, and we were able to propagate the xenograph and not only have it available to use in the flank or in culture systems, but we could actually place the tumor in the pons of rodents so that we had orthotopically relevant tumor model that we could start to follow, and it was modified so that we could use bioluminescence. And this cell line and this cell source has been shared around the country, and now, since that's been published, there are about 10 or more, and we're developing new cell lines and xenographs on a regular basis now. So I want to get down to precision medicine. I talked about that last year in adults, but even though there are a few alterations and mutations in this disease, there is heterogeneity. Every child is a little bit different. And again, we can't use a one-size-fits-all approach like Dr. Hood was talking about this morning. So we wanted to develop a precision approach for these children, and we modeled it over the Ivy trial that I did in adults, which was to genomically profile and take that information and make a decision, and then try and treat these children with more than just one drug, both positioned and repositioned agents. Again, taking from Dr. Hood's comment that one drug is probably not going to make a difference, and so we allowed the option of doing many studies and many drugs and open this protocol about 2 years ago now, called PNOC 003. And the workflow and the way that we did this was essentially the same as the adult study. Is when a child came in with an image that looked like DIPG, those children would get biopsied before any therapy, and typically we would do 4 or 5 biopsies in that child at the same setting. And then we would send the tissue fresh for profiling for whole exome and RNA-seq, not whole genome, but we're doing the whole genome now. And then we would match that to alterations and drugs that could fit the alterations and pick 3 to 4 drugs that made a sense. And again, positioned or repositioned agents, up to 4. And that was our feasibility study. This is the workflow that went through that. We could get the information within 3 to 4 weeks convene a molecular tumor board with every child that was biopsied, and then we had a neuropharmacologist and a number of clinicians and genomic scientists that would help us organize that. We would create a report. It would be part of the medical record, and then we would treat the patient after radiation therapy. We also made the decision to create xenografts of all these kids, and we get circulating tumor DNAs or liquid biopsies all along the way so that we could try and develop biomarkers as well. So we went through that process. We had a feasibility study. The first 15 patients, this is the profiling that came up, and you can see again that there is heterogeneity in the alterations that are there. The H3.3 more common than any other alterations, but also alterations in P53 and other things. Some things that aren't really druggable. And oftentimes we're making decisions not only on the mutational abnormality, but also the pathways that were altered in the hopes that we could integrate both somatic mutations with pathway alterations and then treat the children. And these are some of the drugs that were used. So that trial ended about 4 or 5 months ago, and then we amended the protocol to make it an efficacy study so that we now, instead of giving the option for treatment, children are being treated with the therapy that we recommend, and we're gonna look at outcomes. And again, this is a rare patient population, only 300 or 400 patients per year in the United States, so we can't do controlled clinical trials. So we're going to do the best that we can with targets in terms of efficacy and see if we have a hit. And then we're going to go to a master protocol design and hopefully try and get investigational agents added into it. So that's our precision approach. So after that, what do you do? So again, the issue for us is drug delivery. How do you get drugs into the brain, and how do you document that you get drugs in the brain? The blood-brain barrier is very adept at keeping things out. Less than 1% of almost every drug ever gets into the brain, and you never know whether they hit the target and it modulates the target, and what happens after you perturb the target. So how do you deal with that? So we started about 10 or 15 years ago trying to focus on drug delivery issues, both convection delivery and intranasal delivery, as well as systemic delivery, and then trying to formulate ways of trying to enrich how much drug gets in and how long it stays there. And we've been working with nanoparticles for that reason and model systems. We actually have been doing trials with a construct called a nanoliposomal CPT11, so irinotecan, an old cytotoxic agent, a topo inhibitor, and have done some phase 1 systemic studies. But we wanted to say, okay, what could we use that strategy to get that drug into the brainstem of children, and why would we want to do that? Well, we know topo1 expression is overexpressed in adult glioblastoma from the TCGA. From the trial that I just described, all those kids had tissue, so we interrogated the tissue to look at topo expression in those kids' tumor, and it's very highly overexpressed. So we know that the target of irinotecan, the topo, is there. And we've done studies now in model systems looking at the delivery not only of CPT11 into the brain, but CPT11 encapsulated in the nanoparticle, and it's better when you do it that way. And if you do it by convection delivery, it's even better, so that you can optimize drug delivery to a target that you know is actually there in a kid with a brainstem tumor by giving it directly. And we use that model system, and we use that child's xenograph to do this kind of work. And there's a dose response, and it looks like it's a reasonable thing to do. And we've compared intranasal delivery, systemic delivery, and intratumoral delivery. And intratumoral delivery is clearly better. So why do anything else? So the issue again is, can you put catheters in the brainstem of children and give them a drug? Well, yeah, people have been doing that now recently with a number of different drugs. We decided that doing it once was not enough. And so we set out to develop a protocol where, knowing that the residence time of this nanoparticle is measured in weeks, if you put CPT11 in the brainstem in a model, a rodent model, it stays there for like 6 weeks and slowly is releasing that irinotecan. But then it's gone, right? The concentration goes down. So we felt like in order to make a difference in children, we should do this every 4 to 6 weeks. So we went to the FDA and asked them to let us do that. And they said, well, do you think it's safe? So yeah, we think it's safe. So we proved that it was safe, at least in dogs who have tumors. And we have a good connection with the vet school in Sacramento. And these dogs get a lot of brain tumors. And we've looked at convection delivery of this nanoparticle in dogs. We've been able to optimize the technique and the tools and the catheter systems and the placement of the systems with real-time imaging using gadolinium to let us know that the delivery is going to be where it is without any backflow. And we've seen regression of these tumors, these spontaneous dog tumors, and we've done it over time. So we had the data to support taking that high risk for a potential high reward in children, and went to the FDA to do that. It took us 2 years in debating this with the FDA, but they finally gave us approval to do that. We also, so the idea is brainstem glioma. We know that the target is there. We'll get tissue from those kids. They'll finish their radiation when the tumor volume is small, and then we'll put catheters in at the end of radiation and start with real-time imaging, deliver this nanoparticle of CPT11 into those tumors, and then every 4 to 6 weeks continue it until they progress. So this is just a platform, and the platform is important because if you can do this and you can show the FDA that it's safe and you can show to families that it's reasonable, and if it makes a difference, that would even be way better. But that could be a platform for putting multiple agents into these nanoparticles or multiple drugs and leave permanent catheters into these kids and convect them over time so that you could have 3 drug cocktails or 4 drug cocktails or other agents that you can put in that. So this is the beginning. We're very excited about doing this, but it's technically challenging, and every kid that we do, it costs a ton of money. So and we're philanthropically based, right? So there's no drug companies that's going to pay for this. So we did get a foundation to give us $2 million to do this in the first 7 or 8 kids, and then hopefully 10 kids. And then maybe if we show that the platform works and it's reasonable, we can get additional support from maybe a drug company. It's hard to say. I mean, there's no profit margin in taking care of a kid with a brainstem tumor. There's just none. So you can't get companies to do that. But we did have a company who gave us the drug, and that's great. And we did get a philanthropic partner, and that's great. And we're going to start this process, and we hope it'll make a difference. And then finally, this issue about immunotherapy and targets. The K27, the H3.3 K27M mutation actually turns out to be a neoantigen, and it is recognized on the cell surface, and it allows the development of novel peptide-based vaccines, and it's homogeneously expressed in tumors if you just look at tumor tissue from these children. So it's probably a founder mutation, it's probably a driver mutation, and it's probably critical for the development of this tumor and the propagation of this tumor. And Hideo Hokata in our group has worked on very specific epitope binding sites in an HLA-restricted fashion context, and has actually shown preclinically that he can make a peptide-based vaccine that would target specifically these tumor cells. And we finally, again, got approval from the FDA to do this. This is interesting in that it's a first-in-human study. It's a first-in-human study being done in children with brainstem tumors. And so the FDA was a little nervous about it. We're a little nervous about it because you always worry about allergic encephalitis or other problems when you give vaccines directed towards a target in the brain, and then hope that there's not going to be some problem with damage to the nervous system of these children. But we did get this approved. We also got it funded through philanthropy to do this, and we've got a company to create the vaccine. We have the IND in place. This took us about 2 years to get through the process of approval, and we got approval last month. And as soon as we released that the trial was open, we had children and families, contacting us. And that's one of the problems, because we could only treat 6 patients and then wait. The FDA said you can treat 6 patients, but then you have to wait 3 months. So we've done this 6 patients, and we have to wait 3 months to make sure that it's reasonably safe. But it's very exciting because we have this founder mutation, and it's expressed in these children, and it's one of the few alterations that you have, and using a vaccine hopefully will be non-toxic and will target exactly that epitope, and hopefully it'll make a difference. So, and then the final thing I'm going to say is, because I know my time is up, is we also are interested in this target because there actually are drugs, Jumanji D3 demethylase inhibitors, that exist. This is actually, this alteration in epigenetic in the epigenome is actually common in a lot of different cancers, not particularly this mutation, but this is druggable. And we're working with Pfizer now because of preclinical research that Rintaro Hazijumi, I have a polymorphism, I can't say his name, did with that child's tumor, showing knockdown with this demethylase inhibitor with decreased proliferation and apoptosis that was restricted only into the tumors that had the K27M mutation. It's highly specific and highly effective, not effective at all in the non-K27 wild type group. So we're now working with Pfizer to develop a brand new drug that is CNS penetrable, to actually get their chemists to make this drug in a platform that truly gets into the brain. And we've been working with them for about 1.5 years now. They're very keen on helping us to develop a drug that we can use, and they put their whole medicinal chemistry group on it. The plug for them is that they're doing it, but they also hope that it'll work for glioblastoma and other cancers as well. But we'll probably have a first-in-human trial in pediatrics with the K27M mutation. And if it doesn't work too well, we're also working on a soluble form that we can give by convection delivery as well. So it's really exciting. And I only put this up to say everybody's doing PD-1 inhibitors, so we are too. And we have a company now that's working with us called Regeneron with their PD-1 inhibitor that we're just getting ready to open, where kids with DIPG will get their PD-1. But all those kids are going to get a biopsy before we treat them. So we'll at least know something about their tumor and whatever biomarker may correlate with outcomes. Again, we don't have randomized trials in DIPG. There are just not enough patients. And I don't think parents would be very accepting of a randomized or placebo-controlled study, but we are doing that. So we have a spectrum of approaches based on high risk, high reward, I hope, that are significant based on tissue correlation, biology, and maybe it'll make a difference. I started out with a strategy through the PNOC, and Dwayne will know this very well. We also had a dendritic cell vaccine trial that we wanted to do and worked with the company for a long time before they pulled out. That's a problem. It's a problem to get engagement of pharmaceutical groups for diseases like this because they're so rare, and they're worried that children will get hurt, but they're all dying. They all are dying. So you've got to take high risk and high reward. And anyway, so I'm very pleased with this portfolio of protocols that we're doing. The last slide is this. the NCI, this is, it took me a while to get all this data, but the NCI does not support a lot of pediatric cancer research in terms of their whole portfolio. And when I started to filter down from what the NCI gets into what actually gets into pediatric cancer, of all of their funding, it was only about 4% of the portfolio is in all pediatric cancer, not just CNS, but pediatric cancer. Less than 1% of the budget goes to CNS tumors, less than 1%. But the number of years of life lost of a child is huge. It's huge. If a child dies at 9, then you've lost 80 years of life. And every child that dies, that's another 80 years. I mean, when you start thinking of years of life lost, it's huge. And other gliomas in children as well. So it would be really nice if there was more funding and that's why we deal with philanthropy, because that's where the source of revenue is, to do the research that we're trying to do, and these are expensive studies. And occasionally some pharmaceutical groups, but not too many. But anyway, we're hoping to make a difference. We're hoping to be a bit, significant as we can in this very, very rare incurable disease, to see if we can push the mark. And hopefully in the next couple of years we'll have some data about this that'll, I hope, make a difference. So thank you.
Thanks so much, Michael. I'm really glad that you could address pediatric brain tumors, because I believe they're the number 1 or 2 cause of cancer deaths in children. Number 1 now. Used to be leukemia. And along the lines of segueing into immunotherapy, which is going to be a big topic this afternoon, I'm very happy to have Dr. Jerome Graber talk. Dr. Graber joined our group at Swedish Neuroscience Institute and the Ivy Center last year, having trained at Sloan Kettering and worked in New York, and he's bringing an increased focus on clinical trials, along with Dr. Binkers, who is already with us. And I'm going to have him speak about personalized immunotherapy. Thank you.
Hi. We've kind of wandered along a lot of different levels of topics today, from like macro medicine, systems biology approach to entire healthcare systems, down to people talking about looking at literally single cells. So I'll try and stay somewhere within those bounds, and maybe kind of, as I'm listening, bring up things that people have touched on and that all of us, I think, are trying to tie together in some way for both individual patients and then our entire patient populations. I do have to show my disclosures, that I do have some relevant disclosures, and kind of looking at some of the pictures and thinking about things that people have been talking about this morning. I just wanted to show a variety of pictures to really kind of bring home that we're talking about not one disease. And it was long suspected, when it was first described, they called it multiformy because they recognized immediately that it takes multiple forms. We know that's true at so many levels now, and more deeply than before. But when we meet patients that all carry the same diagnosis, we meet people with tumors that look like this. We meet people with tumors that have minimal contrast enhancement, but this more infiltrative gliomatosis cerebri pattern. And we deal with tumors that look like this, where tumors are actually spreading through cerebrospinal fluid. So people with the same diagnosis, people who get called the same disease, people whose cells get submitted to different researchers and analyzed, it's not just at the molecular level that they're different. They are very, very different and heterogeneous in their appearance, in their behavior, and in their underpinnings. And I think when we start talking about immunotherapy, we really have to be ready to deal with an even extra level of complexity, because this is really kind of a host-parasite interaction, where you have a disease that is constantly changing, is multifocal and heterogeneous in every single one of its cells, and then you have a host, the patient, whose immune system is also changing and responding in a really dynamic and heterogeneous way that we really don't fully understand. And then when you try and put those factors together, it gets even more complicated. So we need people like Nitin and others to kind of tell us about the systems biology approach and bring together people from different disciplines to try and get a better understanding on this. But kind of this one approach, one molecule, one drug, it really just doesn't make sense when you get any kind of grasp of the conceptualization of this disease. And I think, as multiple people have cited, the pediatric oncology world was way, way, way ahead of everybody else in this. When they started seeing true successes in pediatric oncology, it's when they started combining multiple drugs that work in multiple ways. And they were ahead of us by 30, 40 years in that, but really made headway. There's a little bit complexity because the way that drugs are tested and approved is used to thinking very simplistically, and we have to finally heed the success of our colleagues and move beyond that. So hopefully we're finally getting to that point in the not so distant future. So like I was saying, when you look at these cells, they really have very, very different cell types within them. If you get samples from little different parts of the cell, they look really, really different. You're dealing with tumor stem cells, you're dealing with necrotic areas of dying cells, you're dealing with cells that are infiltrating or palisading and moving away to either flee conditions that they don't find favorable, or moving towards areas and conditions that they do find favorable. You're dealing with infiltrating immune cells of many, many different types, some of which are actually protecting and sustaining the tumor cells, some of which may be trying and failing to attack or control or limit the disease. And really interestingly, like Vivian Tabar and a few others have shown, the abnormal blood vessels, some of them are normal blood vessels that have been induced to respond and open up around the tumor. But some of those vasculature cells are actually tumor cells that are no longer even glial, but they're actually forming tumor vasculature. But if you look at them at the single cell level, they carry the mutations that prove that they are actually tumor cells that are blood vessel cells. And they are different and distinct. So we're dealing with lots of different things within this one tumor that kind of is all given one name. And you can see that in the very, very basic pathology slides. I think the main point here is that you cannot draw a line. There is no border. Even on MRIs where it looks like there is a firm border, and even in patients who get gross total resections where they have a wonderful MRI and their scan looks perfect or near perfect, what we really know at the pathologic level is that there are tumor cells and reactive cells far beyond what we see on the MRI. That we have to address and think about. So this is not a local disease, but it is a brain-wide disease, and it has the potential to cross barriers and move into new areas. So when we talk about drug delivery, we also have to hold that into account. That's also seldom discussed in immunotherapy, but different compartments, people just talk about the CNS, but actually different parts of the central nervous system are different in their ability for different immune cells to infiltrate and respond within. And then we start talking about leptomeningeal disease through the CSF, that is a different immune environment. So anything we talk about for immunotherapy has to kind of remember that and bear that in mind, that as the tumor moves through different tissue, the immune system is not exactly the same in its ability to reach different areas. And different areas of the brain have different tolerance for how much inflammation and what type they will tolerate. So going back to the multiforme base of this disease, the immune system too, you have to think of as this really, really complex process, parts of which are beneficial, parts of which are extremely harmful, and you're dealing with very, very different cell types. They interact with the tumor blood vessels as well as normal blood vessels in both positive and negative ways. So there's multiple different cell types that you may want to stimulate or suppress. They interact with each other in ways that are really important, and then you have to get those cells where you need them to go to interact with each other. If you're trying to get a drug into the CNS to CNS resident immune cells or ones that have been drawn into the tumor and taken on a phenotype that helps the tumor itself, you have to be able to get your drug into there as well. There's a lot of enthusiasm about antibodies, but the ability of some of these large antibodies to cross into the CNS, if we want them to interact with CNS resident cells, is somewhat restricted, but obviously less so than we used to believe. But there's kind of a dearth of literature on that, even for things that are in common clinical use today, of knowing how different kinds of antibody types truly penetrate into the tumor itself, and not just into CSF, which is easy to obtain. So I really like this quote from Dvorak about cancer being a wound that never heals, because the other thing that we talk about is when we talk about immunotherapy, well, We used to think of vaccines, you're talking about vaccinating somebody against something that shouldn't be there, against a virus or a bacteria that should not be present in the body. But we have to remember that cancer cells do come from our body. So they have their passport and their visa to be present within the body. And the immune system has all of its appropriate checks and balances to recognize what is something that came from it and what is not. And the system where it's supposed to recognize body cells that have become dysfunctional or damaged or abnormal is very, very tightly controlled. So when we talk about vaccine therapies, it really is very wildly different immunologically than vaccinating a person against something that is not supposed to be in their body, especially something that is changing. So it's kind of like if you could imagine someone trying to vaccinate you against a wound. It doesn't seem to make much sense, but that is kind of what we're talking about. When we do talk about abnormal antigens, I think there's a lot of promise and a step forward there, and I do want to talk a little bit about the rindapepimut trial a little bit later as an example of that approach and what we can learn from it in both good and negative ways. Just briefly, because people have cited this before, we do have to operate within the context of changing, standards of clinical care. So as we're learning about the aspects of this biology, a new standard of care came out in 2005 with adding temozolomide, and then we kind of had to catch up after the fact and learn who are our responders and non-responders. So certainly when Dr. Hood was showing what I thought was a fantastic slide about kind of the inefficiency of modern, simplistic clinical medicine, where you put large numbers of people on drugs, some of which are very expensive, but really you're only getting a benefit in a small subset of those people. It just is very wasteful and inefficient. But that's what we've been kind of forced with our current system. So we're giving temozolomide initially to every single patient, and only after the trial, because the trial was designed that way and well and to be learned from. Initially, you give temozolomide to all of your patients, but after the fact, we learned that you do have a fairly reliable biomarker that it is a minority of patients who are responding to the drug. So then you probably don't need to be exposing all of your patients to the side effects in the population that is very unlikely to benefit from it. And from a healthcare system standpoint, you don't need to be wasting that money on people who are not going to benefit from that drug. So then if you're in a group that's going to respond, that's nice news for you. But if you're in a group that's not going to respond to the drug, you need to come up with an alternative. So we're already talking about taking people who've been labeled with one diagnosis of GBM and now splitting into smaller and smaller groups. And it starts to approach the situation that we were referring to about dealing with small numbers of patients with the disease, and then how do you convince a drug company to get financially interested in funding a trial when you're talking about smaller and smaller pieces of a pie. So then as this other progress with different dendritic cell vaccine and immunotherapy approaches has been evolving, there is another new standard of care with the approval of the Novo TTF device, and that adding this device on to standard of care after the completion of radiation and temozolomide and during maintenance therapy with temozolomide showed a significant benefit. This is kind of a new challenge that was not on most people's radars, and the mechanism of which is not fully understood yet. Unlike a lot of the other drugs that have been in the system, we think we know that this device works by altering the physical mitosis and then the tubule structure that allows for invasion and migration and movement of tumor cells, and then fortunately seems to leave the normal cells completely unaffected because they're not using those pathways. What we really don't know almost anything about yet is how does this device then interact with some of the other things that we're thinking about in the biology of the disease. How does it affect tumor vasculature cells? How does it affect normal blood vessels? What effect, if any, does it have on immune cells of the many and various subtypes and their movement and migration? And there's really a dearth of research on that topic, but then we talk about wanting to add these things on to what is now the standard of care in this disease, but not utilized by all patients. We don't yet know for this what we know about temozolomide and MGMT. We see that there's clearly an average benefit and that it is a sustained one, but we don't know, like we do for temozolomide, is that a benefit that's seen, which is a big benefit for a minority of patients that we don't know how to identify or predict who they are, or is it a little benefit that's true for everybody? So hopefully there will be some follow-up studies that then help us predict and find that out, and then rationally apply this therapy to the people who will benefit from it the most, and then not waste it or put up with the side effects in people who may not be benefiting. But I don't think we know enough about the biology of this device yet to really determine that and move forward in that direction, but we're going to hopefully need to. So then referring back to what people have touched on from the Cancer Genome Atlas, we're now kind of getting multiple layers of that people have referred to before. So kind of the first couple layers of data were about genetic molecular signatures, RNA expression, and protein expression, breaking down GBM into 3 to 5 subtypes. I think most people accept now that there's at least 4 to 5, with some rare variants that are driven by certain believed to be baseline driver mutations that then lead their behavior. So what do we know about these different subtypes in the context of looking at broad spectrums of disease and applying rational therapies? In addition now to the molecular subtypes, as a couple people have touched on, people have now looked back and said, you know, how does this relate to immunotherapy? And separate from different tumors having different common antigens or kind of antigenic loads or numbers of mutations and abnormal proteins that might be targets for different immunotherapies, there's also been a small amount but really nice work looking at the different subsets to say that some of these tumors have a greater preponderance of kind of immune suppressive phenotypes within them. Like especially the mesenchymal subtype clearly carries kind of these immune-mediated tumor supporting signals like STAT3 and interleukin-6. I'm really interested in Amy Heimberger and her group's work on that topic, and that some of these may relate to kind of the broader immunotherapies like the checkpoint inhibitors of CTLA4 and PD-1, PD-L1 system. Other tumor subtypes really don't have that signal, so maybe we should not be putting people with those kinds of tumors into those trials. Not much clinical work to really tell us if that's true or not. But again, if we just put every patient who has a diagnosis of a GBM into these kind of broader immunotherapy studies, we may really be diluting the signal of who's benefiting or not. So hopefully kind of that basic work will go on in parallel or in tandem with the immunotherapy trials to make sure that we're putting people in the trials to really find out if the drug works for people who it should work for and it's rational for, and then not diluting our signal and kind of throwing out a baby with the bathwater by including people in the trials who are very unlikely biologically to benefit from a particular treatment. Certain other things, I think often what gets ignored is the negative data, but in some ways the negative data is often the most interesting to me. So though certain subtypes clearly had certain signals for immune suppression or potential benefit from checkpoint inhibitors, there were certain kind of universal things across the different subtypes. So one of the ones that interested me the most was this signal that across all the tumor subtypes, you saw really kind of dramatic reductions in interleukin-2, which is an incredibly important cell growth, stimulation, and survival signature for T lymphocytes. So that would possibly suggest that anything you do for any of these tumors that depends on activated T lymphocytes getting in, surviving, and doing their job will not work. Because without sufficient interleukin-2, you cannot sustain a proper T lymphocyte response. Some of the innate immune cell signatures across the tumor types did also appear to be not very different. So this may help guide us in the kinds of immunotherapies that may not work regardless of type, or that may be theoretically beneficial across the various subtypes of cells. So we might not have to divide up every little tumor type into its one little slice and do that little trial for that rare subset of diseases. There may be things that we can say, this should theoretically work for everybody with this diagnosis, and there may be times when we can kind of lump groups together. So I thought some of this work was extremely interesting, and it's interesting that it kind of correlates with the molecular subtypes very, very tightly, some of which makes sense and some of which there's not really a logical known reason why that would be. And it raises some questions like Nitin referred to when you talk about systems biology, you know, how much of this is cause and effect versus just a correlation? So the GAP project, I think, kind of takes things forward a little bit to the next level that we discussed earlier in thinking about when you look at one tumor and look at different parts of it, how is it different? And right now we just kind of classify, we say somebody progressed and well, what we were doing didn't work. But we could potentially take data like this, and when people do progress, we could look at, well, where did they progress? And does that tell us which biology of their tumor is the part that was resistant to treatment? And when Dr. Hood was kind of showing the Hubble telescope and the stars, I actually really liked that picture, and talking about that these things exist in 3 dimensions. They really exist in 4 dimensions, with the 4th dimension being time. These are tumors that evolve and change. They're already multiple cell sets with the host's immune system interacting with them in a 3 and then a 4-dimensional way. Our patients don't die of the tumor that gets resected. They die of the tumor that comes back after treatment. And people say, oh, well, we can't get that tissue. But the reality is, you know, the benefit of re-resection has been kind of confirmed over and over. And we do get that tissue. And that's really what we should be learning from the most is what is the biology of the tumor that comes back? You know, how is it resisting disease? We've learned some stuff about radiobiology, about mechanisms of radioresistance, but we're going to have to expand that substantially. What are the mechanisms of angiogenesis resistance? What are the mechanisms of molecular resistance from these agents? And then what are the mechanisms of immune resistance if we treat people with immunotherapies? If we can mount an antigen-specific immune response and it infiltrates the tumor, why then does the tumor come back? And again, the rindapepimut study might give us just a little hint of how those studies can be done, and we can learn from them and move forward. So these are kind of the different points that I've already been talking about, but really kind of focusing on what's going on within this entire complex tumor of different cell types, how is that changing over time, and how are all of those cell types interacting with the treatments that are given and the host's immune system. If we're going to really be successful with immunotherapy, we have to really learn about each of those things. And then people from these very widely different disciplines have to form fruitful collaborations and really understand what each other are doing rather than kind of looking at things piecemeal. And that's where we need our systems biology statisticians to help us out. And then how do we apply that kind of data that's complex to clinical trial epidemiology, which is really used to just looking at controlling one factor at one time and then waiting to see what happens. So a couple other points that come to mind going back to the immunotherapies. There are some really kind of studies that I think didn't get that much attention, but kind of point out some actually simple things that surprisingly there are single factors that are predictive. So some of the studies that have been done that Dr. Cobb's mentioned and various other work saying that the immune system systemically clearly goes through changes long before people are diagnosed. There's interesting stuff looking at allergy predispositions in people who later develop glioblastomas and gliomas. There's immune markers of that people have gone back and looked at prior to diagnosis. There's the Scandinavian study that found immune responses long before people were diagnosed with disease that clearly predicted something was wrong with their whole system. And then some pretty simple studies looking at something as simple as CD4 counts. So there's a group at Hopkins that looked. So we know that temozolomide causes a selective CD4 lymphopenia compared to its effect on other immune cells. And it depends on the MGMT expression, not of the tumor, but that CD4 cells actually don't express much MGMT naturally. So that's probably why they're more affected by the temozolomide. There should be a homeostatic response within the immune system that recognizes it doesn't have enough of that cell set, sends out cytokines to stimulate their release and generation from the bone marrow, and that doesn't seem to occur. And what this group found was that patients who were on standard treatment, a subset of them really had significant declines in CD4 counts, and that there was a very strong correlation between low CD4 counts in these patients and their overall survival, and that did not relate to infections. That would be the obvious, well, they had a weak immune system, then they had a serious infection, and that's what happened to these people, but that was not the case. And it may be that something that simple, which is a simple blood test currently available, could actually give us an early warning sign of before there's clinical evidence or MRI evidence of tumor progression. We also really don't understand that much how bevacizumab affects the immune system. We know VEGF and its receptors are expressed on the various immune cells in different ways, and it does decrease some aspects that we think are important for immunoprotection of the tumor. So we may be able to leverage things that we already are using, have currently available, if we just understand them a little bit better. but we'll need to be looking at these things together with these kind of more complex immunotherapy trials. People kind of looked at these things in a very simplistic way and said, oh, well, if we weaken people's immune system with temozolomide, immunotherapy is not going to work. But we've known a long time before that when the immune system has a mild lymphopenia, that's actually when it's most responsive to things that stimulate the immune system, including just normal vaccines. So the Samson and the others that did the rindapepimut trial of EGFRV3 vaccine clearly showed that when they gave the vaccine, when people had the greatest CD4 lymphopenia, that's when they actually saw the best responses of antigenicity, because you were stimulating naive CD4 lymphocytes that had just come out fresh from the bone marrow, and there was plenty of interleukin-2 around for the CD4 cells to soak up and respond to and kind of start a new immune response. So the EGFRV3 vaccine, most people in the room know, this is a failed study, so this is a negative study that I do want to talk about because I think it's an example of ways we can learn from studies. And I think we should plan all studies in a way that we can learn from them, even if they are negative studies at the end of the day, rather than not learning from why something did not work. So this was a nice example of a simple, straightforward vaccine study. EGFRV3 is expressed in a subset of GBMs. It is a neoantigen. It is not expressed in the body. The immune system should recognize that it's not normal. It's right there on the surface. It's a good antigenic thing for the immune system to respond to. So this was a really good, straightforward concept that made a lot of sense. They clearly showed through several studies that you can vaccinate people and stimulate a systemic immune response to that antigen. It should not cause reactions anywhere else in the body because other cells don't express this oncoantigen. So they set up a nice, well-designed study. They had people with near total resections of their tumor only, which has kind of become a trend, but there's been this assumption that tumors that are bulky and have that immune suppressive local environment will not respond to immunotherapy, but there's really not that much data to prove that that's true. So again, we're kind of looking at a small subset of patients from the very get-go. So when you talk about people who have EGFRV3 and a gross total resection, probably about 1/9 or 1/10 of total GBM patients were the people that were even eligible to be in this trial to begin with, based on some rational stuff and a theory, but not much else. The first three studies really proved that this was a safe thing to do, and there was some suggestion that it was beneficial, so they proceeded to a large randomized phase 3 trial, and at the end of which there was absolutely zero benefit whatsoever. However, I think we learned some simple basic things and verified a few others from this trial, that you can stimulate an antigen-specific peripheral immune response. There was data that they collected that those immune cells did penetrate into the tumor tissue and create the kind of immune response that you'd want. And they did some nice kind of simple, reproducible, widely applicable biomarker studies saying that yes, you can stimulate these cells. They're the right kind of cells responding to the right kind of antigen. They do have the kind of surface surface receptors that can home them into the central nervous system, and that they do hit their target, and that you're also producing the right kind of cytokine milieu for these immune cells to be active ones and not regulatory or weak. And that you could really do studies looking at the timing so that you can leverage effects of the treatment patients are already on temozolomide to give the vaccine at the right time to get the maximum response that you want. And what they found, Heimberger's lab did a work with a subset of patients where they did take out the tumors of the people who failed and had progression of their tumor, and they clearly showed that on the top, the person had amplified EGFR in the tumor cells. They had EGFRV3 in the top right on the surface of the cell. When the tumors came back, there was no more V3 on the surface. They had completely wiped it out. You could not find it anywhere in the entire tumor, but the tumors clearly were growing anyways, and interestingly, they also had re-amplified EGFR signaling for cell growth, even though they were not expressing the abnormal receptor anymore. So I think they were doing the right kind of things from the get-go to learn from the trial, no matter what happened at the end of the trial, whether it was beneficial or not, to teach us a little bit more about the immunobiology of this disease. So I just want to talk about a couple other trials we're waiting on results for that are slightly different. So DCVax has been going on for quite some time, and this is hopefully a multivalent type of vaccine, not just against one antigen. It's derived from patients' own dendritic cells, so you have the patient's own individualized immune system, and then you're pulsing and stimulating it with the patient's own tumor lysate. So you don't really know what antigen you're stimulating or not, but it should be patient-specific, and it should be specific to their own immune system, which should theoretically be good from a safety standpoint. And again, they had this requirement that people had to have a gross total resection, because they needed enough tumor tissue to then do the tumor lysate and create the vaccine, but also partly for this theory that's really never been proven that if you mount an immune response but you have a bulky immunosuppressive tumor environment, it won't work. But again, we've never really proven that for sure, even though it should be a sound theory. It's something that really could be looked at in a small subset of people and established, should we be designing the trials this way or not. So they have completed accrual to this trial, and the patients are being followed. We'll hopefully get results later this year. I think one of the advantages of this trial is that it's multivalent in the sense that you should be getting the patient's own tumor of whichever subtype it was or is, looking at whatever antigens are present rather than just guessing and applying it across to a really heterogeneous population of patients and tumors. But this trial was designed, before NovaTTF was approved, before some other things have come into standard practice. So they also designed it to allow crossover at progression, which may create some statistical problems in analyzing the data. But it'll be interesting to see the results of this trial, and then hopefully a lot of kind of the more basic science and translational investigations into it. If they acquire tumors at progression, and then look at kind of biomarkers, tissue markers, and serum markers of the immune response in the study, so that either way that the outcome is for this trial, we learn a little bit more about immunotherapy from doing it. And then kind of in a slightly different vein, there's also the ICT-107 trial that's actively enrolling worldwide right now. We're also taking patients' own dendritic cells. However, you're sending them to a central lab, and you're kind of stimulating them against a panel of common antigens that should be variably expressed across the different heterogeneous tumor subtypes. They are getting tissue biomarkers of the study to hopefully confirm in individual patients whether they did give a vaccine that stimulated an immune response that should have worked for that individual patient's tumor. Again, we're looking at a very, very select subpopulation of patients, however, in which there's absolutely no residual tumor after surgery. And then we're taking that subset of patients and then literally cutting them in half, because patients have to have the appropriate HLA type for this process to work. So again, we're looking at a really small subset of GBM patients as a whole. So then when we interpret the results of any of these trials, we have to really ask ourselves, what does this mean for our entire patient population? And as trials are looking at smaller and smaller subsets of patients, it's going to require greater and greater collaboration across different centers and really running worldwide trials to get the numbers of patients that are eligible to get in the trial to begin with. I think I'm almost up for time. I will stop there, but I'm hoping that we will learn a lot from these immunotherapy trials. People are already talking about taking them into kind of the second and third generation of starting to combine these various immunotherapies in different ways. Can we combine, targeted vaccine therapies together with checkpoint inhibitors to augment them and kind of broaden the immune response across different subtypes? Is that something that's safe to do when you create a less specific response? Will it augment things? And then one picture that's emerging in many of these immunotherapy trials is that if we do stimulate an immune response and inflammation within the brain, then we're dealing with patients who present to us with inflammation in their brain, which can be very clinically symptomatic. So then we need to kind of go back to our really core basic clinical care of patients, because we're going to have to be able to symptomatically support them to get through the symptoms clinically that they'll put up with when they're in these trials. And then we'll have to kind of resist the urge to constantly give immunosuppressive steroids that may, get them through the reaction they have to the treatment, but also blunt any effect that it might have. Any questions?
Thank you very much, Jerome. Thanks. You want to stay up here? And let me see. Michael, could you come up and have a little panel discussion about some of the some of the information they discussed. Does anyone have any questions of Dwayne?
I think both of you in your talks touched on the concepts of and the importance of biopsy, rebiopsy. I wonder if you could maybe discuss a little bit more specifics for the patient population you described. What do you think the role of upfront diagnostic biopsy is for brain sampling patients in the context of the only clinical trial? Is there utility of thinking about incorporating this into practice? And then the same in terms of disease recurrence or progression, where maybe by imaging or symptomology you're pretty convinced this is recurrent disease. But what are your thoughts then of the clinical utility of biopsy or resection, maybe in the context of the study or even outside of that? Just from your perspective.
Mike, could you repeat that?
I'll start with.
Can you repeat the question, Mike?
The question is when should biopsies be done in essence outside of clinical trials, and if they're done within clinical trials, how should they be done? I think in the IV adult trial that we finished, we wanted spatially relevant biopsies. So these in recurrent glioblastoma, where we could look at both the enhancing and non-enhancing regions. I really wanted to do 4 or 5, but we only did 2 regions or 3 regions within the brain because of the issue of heterogeneity and also to kind of correlate, again, that word correlate, I hate to use that, with outcomes because of some information about drug distribution within infiltrating margins. So it's a lot of discovery, I think. And I think in that context should be in clinical trials. In children, so there have been hundreds done now, biopsies, really no deaths that have been associated with it. It's interesting, families are demanding it because they want their genomic profiling done. And this is happening more and more, right, in clinical practice where patients want to have the genomic information about their disease because they think that there is a way to exploit that information even outside of a clinical trial. And that, of course, is diluting patients who are getting into clinical trials because everybody's getting their whole genome done now. And you're getting a report saying, well, this is what's happening. So I think there's a yin and a yang of it. I think information should be shared, even if you're not in clinical trials, and there should be a mechanism to share that information in large databases so that could be mined. And I think there's a push to make that happen. I think we have to get tissue biopsies, and I think we have to correlate them with liquid biopsies because we can't just keep doing surgery all of the time. So it has to be somehow matched, I think, with peripheral biomarkers as well. But I think extensive sharing of information, whether you're in a trial or not in a trial, is critical to get the kind of information that you need to understand what's a correlation, what's actually cause and effect.
Yeah, I think the last thing you said is the key point. I mean, that's how you answer the question of a correlation versus cause and effect. You need 2 time points of observations to say, this was how things were. We did one thing, and then this is what we saw change. So I think it'll inform, a systems biology approach, and then especially, when patients are in clinical trials of agents that we don't fully understand or in combination, acquiring tissue at the time of progression is something that is common standard clinical practice anyways. And then hopefully we can learn, did our drug penetrate? Did it create the response we expected? And if it did, then what happened? How did the tumor change and then pick up growth? And that hasn't been answered for even some really standard clinical things we do every day now. And if it was integrated into trials and planned from the get-go, we'd learn a lot more going forward.
And I would put in a plug for autopsies, which are going out of favor for some reason. It's only through autopsies that have been done on children, for instance, with DIPG, that it's been now well recognized that these tumors disseminate. And genomically, they're, when they move out of the brainstem and they're in the brain, that they're different. And I think that's another layer of information that, we make it a clinical trial to get access to autopsies, but even when it's done outside of a clinical trial, there's information. So all of this information is really a shame that it's not being utilized. But there's got to be an infrastructure to make that happen. And I think with electronic medical records and people sharing data, that big data will start compressing down into useful information.
I would say from the perspective of neurosurgeons who are often just sort of the technicians are seen that way sometimes, I think there's been a big shift from, at least earlier in my career, to be less nihilistic and more aggressive, especially because of the questions associated with, quote, pseudoprogression, Avastin treatment, these kind of things. So when patients have had a complete resection, for instance, and they've done well for a while, and then something shows up months or a year or so later, instead of being less invasive, I think we've become more invasive. But I believe that's more conservative in a way, because you're actually knowing what you're doing, you're knowing what you're treating, and you can hopefully either not treat someone for something they don't need to be treated for, or guide your treatment based on real, hard data or evidence.
And I mean, I think surgery is actually going to be a part of immunotherapy in multiple ways. In A, creating a beneficial local environment for immunotherapy to work. And then right now, the standard thing to do is if people are having an immune response in tumor that's too symptomatic, people give them a big pulse of steroids, and then you've just wiped out any potential benefit of your immune response. Maybe we should be revisiting surgical resection, the same as works in necrosis, to alleviate symptoms, but then allow the maintenance of the immune response.
Right. I mean, scientifically, there's a basis for that, because I think people have shown that glioblastoma tumors in particular produce huge levels of a protein called TGF-beta, which is highly immunosuppressive. So if you can remove the bulk of the tumor, you can decrease at least some of the things causing the immunosuppression that would allow and facilitate immunotherapy to work. That's basically why most immunotherapy clinical trials, I guess, require less than a certain amount of tumor residual after surgery. Hayden?
Yeah, Dr. Graber, you mentioned the DC-VAX trial, and I'm sure you're more familiar with it than I am. I was wondering how they prevent against non-specific action of these dendritic cells that are primed with whole tumor lysate. You don't know exactly what antigens you're getting with that, as you mentioned. So how to ensure that it's only going after tumor targets, or if there's a danger it's not.
Yeah, so that was one of the big criticisms of the trial when it was designed, and we were fortunate enough to have Dr. Lau here just last month, 2 months ago, giving grand rounds on this topic, who's really kind of a pioneer for that trial and the basis of it. But that was a big criticism and concern. Oh my God, you're gonna give people multiple sclerosis, you're gonna cause all these nonspecific reactions, but our immune system is designed to know what should be there and what should not. So in reality, we all have autoantibodies and autoreactive T cells and B cells, and they're carefully balanced by regulatory cells, and there are regulatory antibodies that then limit that response. So it kind of gets to the heart of why some of these other approaches might not work, because just stimulating the response is not enough. It has to be a response that is strong enough to overcome the really kind of multi-layered resistance to respond to self-antigens, but then also not be suppressed so much that it isn't effective. So I think it'll be interesting and instructive to compare the DC-VAX trial to something like ICT-107 that is for extremely specific antigens, to see the kind of responses we get. There have not, to my knowledge, been any reports of nonspecific immune reactions so far. Whereas we are starting to see those kinds of things from the checkpoint inhibitors that have this kind of broad, take the brakes off the immune system mechanism. And there have been a couple small but really interesting and thorough case reports of patients who manifested with inflammatory demyelination on the checkpoint inhibitors. It's also going to it already is a big concern with some of the CAR T cell therapies, that even when you are using a different mechanism of very targeted, potent lymphocytes against a specific antigen, you're seeing inflammatory responses, where you shouldn't. And there's a theory that they may be reacting to occult single cell tumor sites of disease that we didn't know were there. But I think that's one of the biggest criticisms of that trial in the beginning, and that has not panned out. But something that hopefully we will learn from that trial moving forward. Is that safe to do? If it doesn't happen, why doesn't it happen? And is that something we can then use within another approach like the checkpoint inhibitors to then limit kind of the dangerous side effects of some of these other immunotherapies?
I actually think that's a really good question because it's fascinating to me. I mean, you don't focus in science on things that don't happen often, but to me, we've treated dozens of patients here, and I'm sure that I don't know how many are enrolled in DC Vax worldwide, but about hundreds.
Over 300, yeah.
Hundreds of patients. It's just striking to me that you're vaccinating their dendritic cells with tumor proteins, firing them up and giving them back, and people have not had some kind of encephalitis reaction. So it speaks to the point.
And they haven't had, like you said, pseudoprogression. So you kind of want an inflammatory response, right?
Right.
In addition to a specific T cell response against a specific antigen or multiple antigens, kind of the ultimate personalized medicine approach. But I haven't seen that. I mean, very much at all. So it seems like you're really trying to prime against anything that's there with a load of a DC-based vaccine, but you can image at least. I mean, I'm sure it's there, but it's just curious that.
I think that speaks to emphasize the work that, for instance, Ralph is going to be doing and other people are doing, and I'm sure Dwayne Mitchell could speak to this, that, the tumor microenvironment is not just like anywhere in your body. I mean, I think it emphasizes the fact that as soon as the immune cells get in that environment, they probably are getting dramatically shut down in terms of function, because it's almost an immune privileged environment. And the patients with these tumors systemically also, this is from work at Duke when Dwayne was there, often will have very poor T cell function systemically to begin with, almost to the point of being anergic to regular exposure to cell-mediated immune function. So, I think understanding the fundamental immunological deficiency, and then the micro deficiency in the microenvironment will really hopefully help us figure out strategies to overcome that, because obviously now it doesn't seem like a big immune response is being mounted based on tumor vaccine to the tumor lysate. Mary?
I have a couple of questions. First of all, Dr. Kratos, is there, in adults, is the H3K27M found in any adult tumors?
Very, very rarely. Very, very rarely, yeah.
Because
That specific mutation, right, the
Yes,
K27.
yes.
I mean, there are epigenetic changes, involving, but not that specific mutation, the K27M.
I'm so glad you're doing the DIPG work, because it's just we so desperately need it.
Yeah.
The other thing I just wanted to comment to Dr. Graber was when I was back at Society of Neuro-Oncology this year, I really felt that, we had this big peppermint study, and then nothing was said except that it was negative. And we were all kind of sad and let down. And to hear that they're learning so much from it, it makes me feel a lot better. The one thing is that I just know, as working with patients and families, there are groups of people who I know are doing better. But you can tell they live longer. And I just hope that at some point we can figure out who those people are. And I know, Dr. Kratos, in your practice, you've always seen people, you just know they're responding to the drug. But we just haven't been able to, with these large studies treating people all generically with the same thing. Can't we start figuring out who these people are now so we don't keep doing this? I'm just getting frustrated.
Well, I think, the NCI is, kind of keen on looking at the extremes, right? Looking at the extreme outliers and who they are. But I think it's very important to do it on the really poor responding patients and those who go out 5 years for you want to know about what it is about them that are different. And that is part of the heterogeneity. I think as we get better imaging and better biomarkers, liquid biomarkers, it's going to be easier. And if, some of the platforms that are being used here can be applied to that question, I think that would be enormously helpful, because then you can stratify even better and follow over time, I think. So imaging biomarkers be very helpful for that patient group that you're talking about, without having to repeatedly take them to surgery.
I think another thing I'd like to say is, DCVax is a sort of nonspecific tumor protein vaccine, whereas ICT 107 is based on parts of six specific proteins. I think one thing we need to add into these studies, and it was kind of illustrated by Linda Liao's talk a couple of months ago here, is there was one patient that she followed for a specific immune response, and that actually happened to be to CMV, which I was, interested in. And the patients got the total tumor protein vaccine, but then they had a very high response just to CMV. So it must have, or you would think it was something to do from the tumor exposure that reactivated that immune response. And that patient is now out 16 years with a mesenchymal glioblastoma. But I think what we need to do is, as we refine the direction of immunotherapy, know how to, and this is work that Dwayne Mitchell is doing, other people, know kind of what we're looking for and how to determine the readout from the T cells that can tell you whether or not the vaccine actually is causing your immune system to mount a big response, and then associate that with survival. Because if you put question mark in and you get question mark out, it's, even if you get someone who's benefiting, it's going to be hard to know cause and effect. So these are going to be things, as immunotherapy moves forward, I think, that are going to become more and more sophisticated, and there will probably be T cell function studies for various things you're vaccinating with to make sure that what you think is happening is actually happening, and that's the cause of the improved survival. So, Dwayne, you want to comment on that at all? Are you, for your studies, I guess you'll talk about that a little later.
Well, I mean, we're going to talk some specific platforms, but no, I would agree. I mean, one of the challenges, of course, in the early phase development of any immunotherapy or otherwise is, until you really are across the threshold of efficacy, where you know you're having true responders and non-responders, finding correlates is challenging. You can stratify maybe with progression-free survival, overall survival, but you don't really yet have, in many of these studies, a definitive group of patients that you can classify as clinical responders because they're not randomized studies. So until you have that data, sometimes it's a little bit hard to know if you're looking at outliers of the disease course or if you're looking at responders to the intervention. So that's
right.
A challenge. And I think, the other point is, if you're subtherapeutic, you're not, so lack of toxicity can either be due to very good specificity of your treatment, which is what we're hoping for, but it can also be that we haven't crossed the threshold of meaningful immunologic responses yet,
right.
Clinically meaningful, and therefore haven't crossed the threshold of clinically meaningful toxicity. So I think these are all things that are just some of the challenges when you're doing these early phase studies. Is you want to examine a lot of these markers, but there's finite finite resources, and I think some of the infrastructure that you talked about, Mike, I think if we had a better way of routinely archiving samples, even from early phase studies, and having access not just to the data, but to people that maybe to come in and do, to go back and do additional studies on trials that maybe you have more information on. I think that's another opportunity that we don't always take advantage of.
Yeah, we just started a project literally yesterday afternoon on a patient I operated on yesterday, where we have collaborators who are studying specific T cell responses from the blood and from the tumor. They're going to try to extract the T cells from the blood and the tumor and compare how these T cells are reacting against specific things. And I think more studies along those lines will be very informative, because it may be that even if you're taking the blood of a patient, it doesn't have anything to do with what's going on inside the tumor. And we really need to know what's going on with the T cells in the tumor, if they're even functioning at all. So that's kind of a new era that we have ahead of us. Great. Any other questions right now? So it's 12:11. We're going to reconvene in about an hour after we have lunch, which goes from 12:15 to 1:15. So I welcome everyone to. Claro, would you like to tell us where to go or anything?
It's just right back where breakfast was.
Right here where the exhibitors are, and look forward to talking to everyone. All right, thank you.